Bismillahirrahmanirrahim. Assalamu alaikum. As you know that we were doing the developmental disturbances of the oral region, and we had completed the disturbances in size. And today we are going disturbances in number also we have completed. And now today we are going to start disturbances in eruption. In disturbances in eruption, there are four topics we will do: premature eruption, delayed eruption, impacted teeth, and eruption sequestrum. Premature eruption. Disturbance in eruption, basically the eruption times for deciduous and permanent teeth are variable. It is therefore difficult to assess the eruption times for any given individual. Only when the eruption time or sequence is obviously outside of the normal range, then can one consider that an eruption exists abnormally. Now, the premature eruption, erupted deciduous teeth present at birth are termed as natal teeth, and deciduous teeth that erupt during the first 30 days of life are termed as neonatal teeth. Premature eruption usually involves one or two teeth. The most common teeth affected are deciduous mandibular central incisors. Although the cause of this phenomena is unknown, but there is generally a familial pattern is seen. Natal teeth and neonatal teeth are usually part of the normal complement of deciduous teeth. They are not supernumerary and they should be therefore retained as if possible. Premature eruption of permanent teeth corresponds to premature loss of the preceding deciduous teeth. This becomes readily apparent when the single deciduous tooth has been permanently lost. In the event that the entire permanent dentition is obviously erupting prematurely, the possibility of an endocrine dysfunction such as hyperthyroidism should be considered. The next topic is delayed eruption. Delayed eruption is a relatively uncommon occurrence. It usually refers to the first appearance of deciduous teeth relatively to the normal age range. It can be idiopathic or it can be associated with certain systemic conditions such as rickets, cleidocranial dysplasia. Normally, it doesn't occur, or cretinism. Local factors can also contribute to delayed eruption, such as gingival fibromatosis. Gingival fibromatosis is in which dense fibrous connective tissues impedes the tooth eruption, and it can result in delayed eruption of the deciduous dentition. Now, the treatment lies in treating the underlying cause, like if there is a systemic condition or the causative local factor, then if we will treat those factors, then the problem can be alleviated. In conditions such as cleidocranial dysplasia, the pathophysiological basis for non-eruption is unclear and no known treatment exists. Delayed eruption of permanent teeth may result from the same local and systemic condition that give rise to delayed eruption of deciduous teeth. The next topic is impacted teeth. Teeth with eruption that is impeded where physical barrier are called impacted teeth. There are many examples of impaction. The barriers which can cause which can cause the impaction of the tooth, or which can cause the impairment of tooth eruption they are dental crowding. Dental crowding can cause impaction of tooth. Then supernumerary teeth, some odontogenic cysts, and odontogenic tumors, particularly odontomas. They can cause impaction. Although virtually any tooth can be impacted, the most common impacted teeth that are seen are mandibular and maxillary third molars, followed by maxillary cuspid, which are followed by mandibular secondary molars, and then supernumerary teeth. Impacted third molars have been classified according to their orientation within the dental arch. Then, how are they impacted? Like the position of the tooth in the dental arch. Mesioangular, if it is positioned mesially. Distoangular, if it is positioned distoangularly. If it is lying horizontally, then it is horizontal impaction. And if it is lying vertically, then it is vertical impaction. The most common type of impactions are basically mesioangular impaction. If the impacted teeth have two types, they can be completely impacted or partially impacted. An impacted tooth that is totally surrounded by bone and is considered to be completely impacted, whereas one that is partly in bone and partly in soft tissue is considered to be partially impacted. Partially impacted teeth, particularly mandibular third molars, may communicate with the oral cavity through the periodontal pocket on the distal aspect of the adjacent second molar. If they communicate with the oral cavity, then the tooth is predisposed to the pericorneal infection and dental caries. The impact teeth that is completely impacted, however, is not prone to dental caries and infection. Individual teeth that fail to erupt for no apparent reason have sometimes been termed embedded teeth, but this term is not usually used. Instead, all examples of delayed eruption are collectively called as impacted teeth. Now, what complications can arise due to compacted teeth? Impacted teeth can cause root resorption of adjacent normal teeth. They can cause infection and associated pain. And compacted teeth can can in future lead to dentigerous cyst formation. And external resorption of impacted tooth can also occur. External resorption in an impacted tooth usually begin in an occlusal area of the crown, and radiographically it resembles dental caries. So you cannot actually differentiate. Now the treatment. The treatment of impacted teeth will vary with the involved tooth and the individual circumstances. Most impacted molars are surgically removed because the maxillary cuspids are important cornerstones in the maxillary dentition. Special efforts are usually made to retain these teeth. To accomplish this, the crown of the impacted maxillary cuspid is first surgically uncovered. Then, with the aid of an orthodontic appliance, the tooth is slowly guided into its proper position in the dental arch, and that's how it is retained. When a physical barrier such as cyst, tumor, or supernumerary tooth cause tooth infection, the treatment must include the removal of the causative barrier. Whether the impacted tooth is removed with the barrier, it depends on the individual circumstances. It varies from patient to patient, from the circumstances to circumstances. Now, the next is eruption sequestrum. What is eruption sequestrum? It is basically a small spicule of calcified tissue that is extruded through the alveolar mucosa that overlies an erupting molar. Usually, it is present in the central occlusal fossa of the molars. And it is basically a small area. It can be a small area of slightly thickened cortical bone in the central occlusal fossa of molars, or it can represent a miniature complex odontoma present in the follicular soft tissue overlying the tooth. Odontoma is basically a benign tumor. You can say that is made up of normal dental tissue, but it grows abnormally. They are usually asymptomatic, and during routine x-rays you can observe them. As a molar erupts through bone into the alveolar soft tissue, bone resorption over the cusp is completed ahead of the resorption over the central depression of the crown, which is known as the central fossa or the occlusal fossa. Due to this, it results in a small island of non-vital bone or odontoma that is pushed out ahead above the erupting molar. It is basically erupted before the erupting molar. Although most eruption sequestra are spontaneously exfoliated and therefore require no treatment, they may occasionally remain in the alveolar mucosa for several days and may be brought to the attention of a dentist. If they are brought to the attention of dentist, or the patient is bothered by the presence of the this eruption sequestrum, then they can be easily removed also. That's all for today, and next we will discuss inshallah disturbances in size. Thank you.